Welcome everyone to our November guest speaker with Dr. Guinn. We'll get started in a few minutes, so feel free to say hi in the comments.
Welcome Alliance HOSA members to our virtual meeting with Dr. Guinn. Good evening, I'm Madhu. Just to introduce myself, I am one of your sophomore council members and I am stoked to be here tonight.
Hi everyone, my name is Rucha and I'm one of your committee leaders, and I'm also very excited to be here tonight and have everyone meet Dr. Guinn. And just as a reminder, we're going to have a QR code for attendance at the very end, so make sure to stay the entire time.
Before we begin, I'd like to briefly introduce our CTSO/organization to any of our new members. HOSA is a student-led healthcare organization that strives to prepare students for the future of healthcare. Through Alliance Academy HOSA chapter, we bring you monthly guest speakers with a wide range of specialties and from all around the globe.
So now, without further ado, tonight's guest speaker is Dr. Guinn. On behalf of Alliance HOSA, we welcome you with warm and wide arms. So thank you so much for joining us. We are truly honored. And we're going to be starting off the discussion, and we will have an opportunity later on for member questions towards kind of the end of the event. So now the floor is open for anyone to ask any questions. So you can go ahead and type them in the chat box. So Dr. Guinn, why don't you begin by introducing yourself and telling us more about your field?
All right. Well, thank you for having me, first and foremost. My name is Lonnie Guinn. I'm an occupational therapist. I have been for almost 25 years. And I am a huge proponent of my particular profession, not just because I've been in it so long, but because it has so much to offer. And that means on both sides. So much to offer as a profession and so much to offer as what we do for the community as well.
Okay, so to begin, why don't you walk us through your career journey kind of from after you graduated high school? How did you go through about it?
Okay. So as we were talking a little bit earlier, I found occupational therapy through an injury in sports. I had a previous profession. I wanted to be a veterinarian up until my junior year in high school. And when I needed to go to therapy to rehab a sports injury, I was exposed to both physical therapy, occupational therapy, and speech therapy. And I got to talk to each one of the therapists and kind of get an idea of what they were doing, different clients, and And while I was there, I just became really interested, especially in occupational therapy, because they seem to have such an adaptable approach to different clients. At the time, they were all athletes. Um, and then talking to them, I found out that there are an innumerable number of environments that you can work in. And I mean, from pre-K to early childhood, all the way through adolescence, all the way through adulthood and geriatrics. And then within all of those different age groups, you also get to do different things in each environment. So working in the younger population, you get to work in clinics, or you get to work in preschools, or you work in schools, or sometimes you work in a clinic where they come in for sports injuries. And then, of course, in adults, you work in hospitals, outpatient clinics, you work hardening and job placement. And then in geriatrics, you also work in hospitals, but you may have a specific center or places that really cater to the older population as well. So there's almost nothing that can't be touched by occupational therapy in the sense of working with functional daily living skills. So once I found out that there was this amount of variety in the profession, it really intrigued me. Oftentimes you find out about a profession and it is pretty direct, it's straight. So you know what you're going to do and you're going to do this for the rest of your life. Well, having the opportunity to change environments really appealed to me particularly. So I began researching the profession, and there was a high growth ratio. There was going to be a large need for occupational therapists in the future, and that was, again, almost 25 years ago. It hasn't changed. So currently, for occupational therapy, there's about an 18% growth each year. So it says a lot about the profession that there's that much more need for it. The income potential was good. The what people do, especially in HOSA, is they have a passion for helping people. And occupational therapy, it really encompasses that feeling more than almost any profession, in my opinion. Now, I know everybody's got their favorites, especially, I'm sure some of your previous speakers, but being able to help people and immediately see the results. And I'll give you some examples. So I worked in Savannah at Memorial Medical Center. And at this facility, I saw people who had car accidents. I saw people who had strokes. I saw people who had degenerative disorders. I saw people who had developmental disorders. So a wide variety of people. But when I was working with them, we were working on a skill that impacted their life. For instance, maybe a client that had a stroke, and I was working with how to help them feed themselves. Now, there's nothing more direct and intimate in someone's life than the ability to feed themselves, especially if they've been doing it their entire lives and then they lose that function. So we incorporate from the evaluation process, we want to look at why is it not occurring? Why is this function not successful? And we look at the neurological aspect of it. We look at the muscular aspect of it. We look at the environmental aspect of it. So we want to find out through activity analysis, how can we best help this particular client feed themselves as independently as possible? And when you're doing that, you see an immediate gratification, not just for yourself because you're helping somebody, but for that person who had lost that ability to then regain it. And that's just one activity of daily living. We worked on how to get dressed, how to be able to move or locomote from one room to another room, how to take a bath, how to clean themselves, all of the hygiene that's involved in that. And then we worked on executive functioning. So executive function is that higher order thinking skills where you prioritize, and if you're familiar with it, and then what kind of occupations may still be available for that person. So let's say they had a specific job that was very physically intensive, and we may need to help guide that new client into a new profession that would suit their current skills. I can give you another example. Um, so currently I work in pediatrics, and I've been in pediatrics for some time. I've worked at Children's Healthcare of Atlanta for several years. And then I've worked in the school system for a long time, almost 20 years in the school system now. And I've also worked in private clinics. Um, each environment, each therapeutic environment has its own very specific benefits. Working in a clinic, you get that one-on-one, very intensive therapy, and you come up with home programs that they'll be able to follow through at home, to enhance the success and the function that you're working on within the clinic. Um, I've worked with people in their house, so home health care, and you're in the environment that they're having the specific difficulty, which allows you a greater access to really detail what the activity and the difficulty within that activity is for that client, so that you can come up with a plan, either adapting the activity or modifying the environment so that they'd be successful again.
Um, the extent that I've known about occupational therapy before this was kind of like how you were saying when you had your sports injury, how occupational therapists kind of help patients kind of get better from that. So there are other like types of patients that you see other than that,
Absolutely.
right?
So we see patients that have had developmental disabilities from birth. We see patients that have had sports injuries, of course. We see patients that have had um, traumatic accidents. Um, we've seen patients that have had amputations. We've seen patients that have had um, either brain or neurological infarcts. Um, so there's, gosh, anything that impedes the function of someone's daily life would be an open client for occupational therapy. And just for the people who have never been exposed to occupational therapy, the name is a little bit misleading, excuse me, where occupation isn't just about a job. So we don't really help people find jobs. That's not our real job. Occupation, in the sense of occupational therapy, is what occupies your time from when you wake up until you go to bed. I know that sounds oversimplified, but everything that you do throughout the day, sometimes we take for granted because we're physically capable of doing those things, or we're cognitively capable of doing those things. But when something happens and we lose that independence, it is traumatic. And so we are that therapy that may help come in and be able to bring either some or all of that independence back to you.
So, going off what you said earlier about treating a wide variety of patients, like people with traumatic injuries and people who are born like that, what is the most common case? Like, is it always athletes, or is it always people who were born that way, or is it always car crashes or something like that? What is the most common case?
So that's a hard one, because each individual environment probably has a higher incidence level of certain cases. For instance, if you work with adults or young adults, traumatic brain injuries and spinal cord injuries because of young men, trying to do daring stunts and getting into accidents, that's probably the most common. In the older population, um, cerebral vascular accidents would probably be one of the most common. Within pediatrics, I see developmental disabilities and autism, things like that, as the primary reason. Now, of course, so let's say I'll take the school system. I have about 70 different kids on my caseload, and there is a large variety of diagnoses within that population. Um, right now, I probably have more autism on that caseload than anything else, but there is still a lot of different diagnoses, which is great because each student really needs something different to participate in their school curriculum. But even children within the same diagnostic criteria are significantly different. So you can take two kids on the autism spectrum, and they could have two totally different needs to be able to be successful in school or in their daily life.
And because of this variety caseload, I'm sure there's like different sort of tools or technology. And we actually have a question from one of our members basically asking, how has technology shaped the field of occupational therapy?
Oh, great question. So technology has improved its efficiency significantly. We have an entire division of assistive technology that we've been using to help people um, be able to locomote or to be able to communicate or to be able to control their environment. And we have done that for, gosh, 30 or 40 years, but they were very rudimentary. And now, because of Bluetooth and because of how powerful even just our smartphones are, they can, with just a small swipe of their finger, control things like the lights, the door locks. They can answer and hang up on not just phone calls, but video chats. They can order food for themselves. They can do things that were no younger kids think, oh, that's not a big deal. But if you can imagine someone who's 70 or 80 years old that has never been able to have, they weren't exposed to those things. And then they've got a situation where they can't cook for themselves, to now be able to have access and make some of those recommendations or commands just using technology. It's amazing. We also use technology for um, amputations. We use technology for stimulation for kids on the spectrum. So sometimes they can't pay attention or even function without an additional amount of stimulation. And so we use technology to help them with increased stimulation so that they can pay attention to a teacher or to a peer. Great question.
And is part of your responsibility helping those kind of get adapted to the technology, or is that more of the assistant technologist that you were talking about?
It depends on the environment.
Mhm.
So some places have a designated assistive technology technician, which is
Yeah.
an occupational therapist that's been trained specifically in that skill. Um, but all of us are trained within school to be able to learn assistive technology. And we are always, just like most all healthcare professionals, we are required to take continuing education. And so within that continuing education, some people choose to do more assistive technology for their learning, or they may do um, something that may be specific to their industry.
This question is mainly for our members and high schoolers who want to go into occupational therapy. What are some recommendations and tips you would give them?
So first and foremost is to shadow, is to do some volunteer hours, to go shadow, to see. And this really probably is a good suggestion for any occupation that you're looking at doing. But to be able to go talk to a therapist and see what they're doing, see hands-on in a clinic or in a school or in a hospital or in an outpatient facility, to be able to go see some of the things that they do, not just research it, because gosh, we can read anything we want on the internet these days, but to be able to see it in person and to see how the connection between two human beings makes such a difference. Um, there are several schools within Georgia that have occupational therapy, which is a required master's degree. Um, and then there's, of course, several with outside of the United States. The let's see, they just opened a new program at Georgia State, but Medical College of Georgia, which is now Georgia Regents University, has a program. Brenau University in Gainesville has a program, and there are a few more in Georgia that are within different stages of opening as well.
And kind of building up, I know this was something that we are talking about before this started, but you were saying how there are certain personalities that are better built for occupational therapy. Could you expand on that?
Sure, sure. So I use the term activity analysis because that is something that we do almost every day. And that is breaking down a functional skill into what are the components. And we're looking at from the skeletal to the neuromuscular to just the neurological to the social aspect of it. And we're looking at all of the different parts and finding out what parts are not functioning efficiently. And then from those parts, what can we do to help it? So if it's from a neuromuscular or from just a plain musculoskeletal, can we build up strength? Can we release tone? Or do we need assistive technology? Do we need an aid of some sort that would help that functional movement occur when they voluntarily want to do it on their own? And then provide that modification and then build. Sometimes we've built different adaptations so that people can hold their bodies in different positions, which are more successful for whether it be eating or feeding or taking a bath or cooking or cleaning or doing some of the daily tasks that they are used to doing.
Okay, so this is another question from one of our members. It says, how many years does occupational therapy require to become an occupational therapist?
So as a required master, it really depends on where you go. I think you can get it done in 5 years at places like Brunel and um, Georgia Regents University. If you decide to do your bachelor's somewhere else, then you'll have 4 years invested in that school, and then a final year and a half to 2 years for your master's in occupational therapy. So somewhere between 5 and 6 years.
Where did you end up going to school after high school? Like, what colleges did you end up going to?
So I went to Medical College of Georgia in Augusta.
Hmm.
It has since changed names to Georgia Regents University.
Okay.
Actually, I think it's changed names quite a while ago.
Oh. And another one of our members had asked us, what are some common everyday problems that you face as an occupational therapist?
Good question. So I'm going to rephrase Medea's question, and it's everyday challenges. So everybody, there's always something new to problem solve, and it really is. It's a challenge rather than a problem every day. Um, Sometimes it might be the actual client is having a hard time. If they're having a bad day, because you're not working with machines, you're working with people, and you have to work within their limits at that time. And so we use a lot of psychology to increase motivation and to increase discipline to keep working at certain things. Um, but then sometimes we're working with financial um, difficulties or challenges because there might be equipment that is really expensive, or and sometimes we have access challenges. So there might be structural things that are in the way of what we're trying to do. And so a lot of times those take a significant amount of time to change.
And I know that like when you see your patients, a lot of the times you are seeing them at some of their lowest points and some of the worst times. How do you kind of motivate your patients at the times where they get demotivated to like keep working towards like getting better?
Oh, that's a great question. So continuing to talk about the goals. During my evaluation process with older children, adolescents, adults, and beyond, I really want to find out what's most important to them. And when we start with that, even if I look at somebody and I assess, oh, this is their biggest physical difficulty, if to them something else is their biggest difficulty, I need to address that because I can lose their motivation. I work on what they feel as though is their biggest challenge, their biggest difficulty, and we'll work through that. And we'll eventually get to things that I think are necessary as a foundational skill. But um, it's really working on what they want to work on. And so when you have those bad days, when things don't go as easily as possible, we can bring those goals back up. We can refocus why we're doing this hard work, putting in the effort, sometimes failing, and that helps. In addition to that, being able to have that client relate to other people who have been in similar situations and have felt down or depressed or have felt, the same way that they have, so that they don't think that they're the only person in this particular situation and there's no way out of it. That, yeah, times are tough, but look at, this person, this person, and this person. They've done what you've done. Would you like to talk to them? Or would you like to read about their story? That helps.
Okay, so another question is, what are some common misconceptions about occupational therapy?
Well, the first one is that just by the name, people think, oh, you help people find jobs. And so that's probably the most common misconception about occupational therapy. The second is, for years and years, when you would watch a TV show or movie and there was a therapist involved, oftentimes the therapist was called a physical therapist, even if they were doing occupational therapy, because occupational therapy was just a confusing term. And so they just left that out and they said, oh, had to go to physical therapy, had to go to physical therapy. And the distinction is typically physical therapy work on gross motor movements, walking, ambulation. That's kind of the big main goal. Of course, they do more, but that's the big thing. But when they're working on those daily living skills, those functional skills, that's actually occupational therapy that you're seeing, just labeled differently on TV.
And what does a basic day-to-day look like to you in your field?
So that again goes back to what environment you work in.
Hmm.
So, and I'll give you a couple of my past profession. So when I worked in the hospital, my day was very different. I went to inpatient and acute care beds, and I worked with patients while they were in that deep need or of necessity. Then when I worked in outpatient, clients would come to me, and so I have a clinic set up with very specific therapeutic modalities that would help for each one of them. So we use e-stim, or we may use vestibular movement like swings for certain people. But so each day is different based on where you work and the particular population that you work in. And then let's take that all the way back down. The same day isn't often the same. The same profession isn't the same day by day. So working in the school system, um, today is going to look very different than tomorrow, not just because I'm in a different classroom, but each classroom may have a different cognitive level of um, of students in there. So where one may have a self-contained classroom, the next day I may be working with a co-teach classroom. And the next guy I go, I may be working with students just in regular general population, so that it's not self-contained at all. Or I might work on the recess or PE environment, and then the next day I may work in the lunchroom or classroom environment. So, and I know I've said this before, but one of the best things about the profession is that as a lifelong learner, you're never going to be bored. There's always something new that stimulates you to want to learn, to want to figure out how to do this, or to figure out a different problem and how to solve that problem.
So you see patients as they come to your clinic, as well as you sometimes go to the patients as well.
Correct.
Got it. Okay. So another one of our members had asked us, when or how did you figure out that occupational therapy was something that you wanted to pursue? And I think you kind of mentioned that before.
Sure. So I did gymnastics as when I was younger, and I got hurt, so I needed to go to physical therapy for rehab on my back. And when I was there, I got to see different therapists doing different things with their clients. And I was just intrigued. Gosh, the human body is amazing. We talked about this before. The human body's ability to not just heal with the right direction, but what it does is it's just amazing. So I thought all of these different professions are really maximizing on that. They're really looking at how the body works and how to make it better. And this is just within the sports arena. So I talked to those particular therapists to get an idea of, what is it that you do? And, I see these people coming in and now they're in a sense fixed, and they go back out and they get to do what they want to do. And when talking to them, by talking to the occupational therapist, it was kind of like this. It was just a long conversation because there was so much that this therapist could do. There's so many different ways that this therapist could help people. And um, I was probably one of those kids that had some attention difficulties in school. And so that was right up my alley because I couldn't get bored in this profession. I mean, there's just so many different ways to do it. And it was an up and coming profession with lots of growth. So from a fiscally standpoint, it really made sense that, oh, okay, well, I won't have a problem finding a job. The income was pretty good. It was very comparable to other therapies. Um, the schooling wasn't ridiculously expensive where I went. Of course, it depends on where you go to school. And so all of those factors came together, and I did go to a hospital and I shadowed for a little while. And I wanted to make sure this was the right choice. I ended up working as a tech at that hospital after shadowing for a while so that I could actually be hands-on and be right next to a therapist to find out, hey, this is how they do it. And as a tech, you get to help do some of the modalities. And that cemented it for me.
So another question I had was, how has COVID affected your profession?
Oh, that's a good question. So, and I hate to give this answer again, but it depends on where you worked. COVID in the school system was extremely challenging with some silver linings. The challenging parts were when they shut schools down. Trying to do occupational therapy over the computer it's very, very hard because a lot of the things that we do are very manual. I use my hands on someone's body, or I'm guiding their movements, or I'm helping them with balance, and I'm using vestibular equipment like swings or rockers, or I try to get them upside down. Things that are significantly harder to do when you're trying to do it through a screen. And so COVID was a big challenge for that part. And then when kids came back, there was a huge adjustment because I'm sure you guys know when you do school from home for several months or even a year, and then you come back to the classroom, it's a big difference. It's harder to pay attention. Your brains have kind of changed in a sense. They've become malleable to doing things a certain way, especially since everything became technology based. Technology stimulates the brain in such a way that when younger children go back to the classroom and they look at a teacher who seems two-dimensional, it's harder for that child to pay attention just because they've been looking at screens for so long. Masks make a big difference because when you cover your face, you lose some of the body language that I'm trying to express and that I'm trying to extract from my client. Because oftentimes I'm working with people who can't talk. And so I have to be able to find alternate ways to communicate. So I read their body language, and those people that can't talk are exceptionally well at reading my body language. Well, body language just, isn't from the neck down. There's so many facial features that give so much information. And when you cover that person's face with a mask, it does dampen how much you can read.
And I know earlier you were talking about how when you were shadowing, you got the opportunity to be part of helping with the technology. What were some of the responsibilities that came with that, and what technology did you actually help with for your shadowing doctor?
Sure. So I'll give you one example. We
Mhm.
use technology in the school system quite often because let's say I have somebody who, for whatever reason, can't write. Either they've lost use of both hands, or they have a syndrome where their fingers don't work very well. They can use technology to be able to dictate things that they would like to write. So it would, of course, again, this is probably nothing new to you guys. You guys probably dictate now, or at least maybe you dictate your text messages while you're driving. But this is something that's extremely beneficial for someone who doesn't have access to doing it any other way. Um, and then we use the same type of technology for our visually impaired students. So we can make something bigger where they can actually see it. We use technology for some of our kids who can't pay attention. So there might be a specific sound or a vibration that's elicited when we want them to refocus either to a teacher or to a lesson. Those are the things that we've used. Well, these are the things I've used in the last 2 weeks. So.
So I didn't know how to phrase this properly, but I just wanted to, it's kind of like a two-part question. So you have patients, right? And do you work with them like for a long period of time, or is it like pretty brief?
Good question. And that depends on the person's difficulties. So
And
I've worked with some patients for as little as 3 weeks because I could figure out what they needed. They were very open-minded and determined that they were going to get back the independence that they wanted. And so we were able to get things done and they were off to the races.
so with your longer patients, I know it's like in the medical field, you have to keep like a strict professional thing, but like if you work with someone for that long, don't you like start being friends and like getting more comfortable with them? Or is it still like a strict professional, like I'm the doctor, you're the patient?
Oh no, definitely not. I'm an advocate of human connection, and that goes across the board because there are an innumerable number of things you cannot get done without that human connection. So I have children who, for whatever reason, they may be scared to risk trying something new, or they may have been in a bad situation. They may have been abused. They may have gone through some traumatic situations. I need to establish trust. I need to be able to make a connection with those clients so that they can make any kind of positive changes. If they don't trust me, then why would they risk trying to do things that they might not be successful at? And that's not just for the long-term clients, that's for all the clients. Because I do feel like, especially within this profession, that since you're helping someone, you develop a relationship. You're just as invested as they are into their growth. And so um, I there's really not a defined line between I'm the professional and I'm still your friend. I'm here to help you. I've got ideas. Let's work together.
And another one of our members had asked, what are some qualities that you think are best for someone who'd want to pursue occupational therapy?
Open-mindedness for sure.
Mhm.
Um, gosh, and the alternative of that would be that everybody probably knows someone who thinks they know it all, and that would probably be the most detrimental. Just because, like I said, I've been in the profession for 25 years. I'm still learning. Not only because there's new situations that are presented to me, but a lot of our knowledge is really malleable. The things that we've learned 20 years ago that we thought were fact, and this is the way science looks at things, and this is the way they are, has changed. It's evolved. And so, pretty much in every profession, but especially for occupational therapy, you want to stay up to date. You want to be able to do continuing education because of those changes. Um, another 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 quality would probably be being personable, because you do want that human connection. You do want to be able to connect with your clients. It's not just black and white. You're really, I mean, I said it before, you're not working with a machine. You're working with a human being. And so to be a human would, that's, I know, and that sounds silly, but you really do have to remember, even though you know all the answers to what's going on, um, for a specific patient, you've got to meet them at their level so that they can understand they're not overwhelmed, and they actually have a positive experience when they come to you.
And as you've said before, how there are different like sectors of like occupational therapy, you work in like pediatrics or geriatrics. To be able to kind of help in all of these, do you go through extra training, extra specialization, or is it more on the job training?
Good question. So in college, you'll do a training on everything. So you will learn how to work with pediatrics and adolescents and adults, and you'll learn how to work with geriatrics. You get the entire knowledge base from school. And then part of our school is to do internships where we go for 3 months at a time and we work at a facility. And that facility might be an adult the first time, or geriatric, or then it might be pediatric after that. And so you get not only the knowledge base, but then you get to apply it in some of these certain places. And that, with some of my peers, I'll tell you, by going on these internships, they've changed which direction they really thought they wanted to go. For instance, I had somebody, they thought for sure they were doing pediatrics. They love kids and they were going to work in pediatrics. And they did an internship at an adult hospital and loved it. And they ended up staying there. That's where they got the job. And that happens quite frequently because, you don't know what you don't know until you know it.
And you specialize mainly in pediatrics.
That's correct.
You haven't done any other sector, or is it just mainly just pediatrics?
I worked through my internships. I did
Mm,
a psych and a neuropsych facility. I
yeah.
did an acute care hospital for adults as well, and geriatrics. And then I did hospitals for children as well. I'll tell you, one of the most interesting things I did was driving rehab. So after an adult has an injury of some sort, or um, mostly their strokes, then we retrain someone on how to drive utilizing just half of their body. And there's different devices that you can use, but it's really neat to do.
So this is kind of going off something you said earlier. You were telling people what qualities they should have in order to go to occupational therapy. But what are some signs that people probably shouldn't go into occupational therapy? Like, what are some things to remember about the profession? So, like, what are some things that students have to remember before going into it?
Sure. So they'd probably be just the inverse of the qualities that I think you should have. Um, if you have a hard time with social interaction, that might be a challenge because you have to be so socially involved in the clients that you work with. Some people have a hard time with personal space, and if you don't like someone in your personal space, occupational therapy is probably not for you because, well, I'll say pediatric occupational therapy is probably not for you because kids get in your space. Um, Adults and geriatrics, you're still going to be close because you're hands on. You're manually manipulating different body parts to help them do or learn or strengthen a certain movement. And so you're going to be within someone's personal space and they're going to be within your personal space. So if you have an issue with that, that might be a challenge. However, I will say, I know in school, now I also train students who have gone that are in occupational therapy and they're doing their internships with us. And some of those are soft skills that you end up learning, where you may have been, you may have had difficulty with personal space, but you've learned how to deal with it.
Yeah, so definitely have to keep that in mind if you wanted to pursue this career. Thank you for that. Another one of our members had asked, what are some common treatments or like some common cases that you see with pediatric occupational therapy? And I'm sure there's a lot of things you see, but what are the most common you've seen in your years in this career?
Sure, I'll give you some highlights.
Hmm.
In the hospital, I used social skill groups quite often because we had students most on the autism spectrum who had a significant difficulty with social interaction. They couldn't read cues. Um, and so, in doing that with those difficulties, they have a hard time making friends. They have a hard time successfully navigating not just school, but social situations. And so, I did groups where we worked on skills, and these are skills that neurotypical um, people like you and I, we apply these. We can watch these things happen as we're growing up, and we figure out, oh, we probably need to do that. And these are hard skills for them. These are skills that need to be taught and then practiced and then applied in real life. So social skill training. Um, Another is motor planning. So I have kids that either have low tone or they have an impaired limb or appendage. And so we do motor skill training where they are working on the strengthening and the coordination of their musculature. In the school system, I work with kids on fine motor aspects. So not just how to manipulate the tip of your pencil, but how to cut color, how to glue, how to be able to open packages from the lunchroom or your snack, how to be able to manipulate what clothing you bring to the school so that you can take your coat off, put your backpack up, to be able to go to the bathroom successfully and then come back without your pants around your ankles. And so there are there's a lot of common treatment approaches to some of the um, most common disorders. Gosh, it really does change based on your environment and the student.
So I had a question. You told us that you were in gymnastics and you had to go to an occupational therapist. Before that, what was your general opinion of this field?
So before I went to the rehab facility, I didn't know that there was even a profession called occupational therapy. Um, I knew physical therapy kind of like everybody else. I saw it on TV, or I might have had a family member that had to go to PT. And so that was the most common thing people had heard. I had I didn't even know that occupational therapy existed prior to going there. So it was enlightening, and it it did stick with me. Even at the time, I still thought I was going to be a veterinarian, but it stuck with me because of how many different things you got to do. And so that's when I began researching it and then asking people, then shadowing, and then end up working as a tech there.
And if you don't mind me asking, when you did suffer your injury in gymnastics, what was some of the treatment you had to go through with your
Sure.
occupational therapist?
Well, I went to a physical therapist
Okay.
at the rehab facility, and it was a back injury. So we did things like e-stem. Gosh, that was a million years ago. That What else did we do? I think we had an exercise program that we worked on after the acute injury occurred, and then we did manual manipulation, e-stem, and ultrasound,
What's an e-stem?
electrical stimulation.
Okay,
So
got
okay, so like the two electrode pads that are
it.
put
Yeah. Mhm.
between the origin and the insertion of a specific muscle, and you can change the frequency and the duration of the stimulation if you want it to um, to work that muscle, or if you want it to slowly get lactic acid, or just for it to contract at a small ratio while it's healing.
So I was gonna ask, when you did decide to go into occupational therapy, how did some of your family members react? Did you have to kind of like convince them that it was a good profession to go into? Because as you said, when you decided to go into it, it was like a growing profession. So did it take some convincing, or were they all for it?
Um, that's a great question. I feel like I'm a bit stubborn. So when I had decided after doing the research, that's what I wanted to do. I think most of my family were pretty supportive. I probably had to do some instruction on what it was so that they knew what I was doing as well. But when you describe the profession, it is it's kind of hard not to like. I mean, there's so many things that you get to do, and again, the profession revolves around helping people. And in our lives, there's no greater joy than helping people. It also comes with a decent paycheck. That helps.
And as you were going through your schooling, as we all know, because we all of us do want to be medical professionals, it does take a lot of schooling to go through. How did you stay motivated? And were there any challenges you faced while you were in college?
I absolutely loved it. I loved everything about that particular school because there was just so much learning going on. There was um, we'll start with the basics. So the occupational therapy, the physical therapy, and the physician's assistants all took the same classes for the first year and a half. So we were in class with those other disciplines the whole time. And that was physiology, anatomy, neuroanatomy, and basic chemistry. So it was it was such a neat experience. For instance, anatomy, and I think I told you guys this. Our anatomy lab consisted of an entire cadaver that we dissected, and we found every muscle, every vein, every artery, every nerve, and we found out how they worked in tandem with each other. We did laminectomies and craniotomies. We found it's an amazing the respect I had for the human body that I thought I had prior to going to school was, oh gosh, it was probably a tenth of what it was when I came out. There was just so much that we learned during that time, and that's just the basics. And then we got into the actual, very specific occupational therapy practices, and in that, whether it be the history of OT or the direction that OT is going, it was really still so fascinating.
So I know you talked a lot about your college, and you were talking about the education you had to be an occupational therapist, but what was some of your, like, other than that, what was your college experience? Like favorite subjects, favorite teachers, or like how they taught?
So
Um,
I'm a science nerd without doubt. So science has always been what I've been drawn to, um, in both the physical science and even the between anatomy. Um, I enjoyed I enjoyed sports in the sense of how the body performs, and so science just goes hand in hand with how that happens. And from a biochemical standpoint to an anatomical standpoint to a neuromuscular standpoint, everything works together. And so how they complement each other, and then when things go wrong, why did they go wrong and how do you fix them, just seem to make sense.
Um, I know that you also said that along with going to different environments and working, you also own a clinic and you see some patients there. Do you own that clinic or do you work there?
No, I work at that clinic.
Okay. And how does that environment kind of compare to like the school environment? Is there any like you prefer maybe the school environment more than the clinic environment or
That's a tough question too,
yeah.
because each environment has its specialty. and they have positives that shine. So in a clinic, when you're working with somebody, there's limited distractions, and there's no limit to how much I can do with that particular student. In the school system, the way that the government has set up related services, which are OT, PT, and vision, we have to stay within the boundaries of accessing their curriculum. So in the school system, there might be things that I know I could work on as an occupational therapist that I'm not allowed to work on as an occupational therapist because they don't have to do with school. So I've done bicycle riding groups for kids in the clinic and at home because it's a good functional and social skill as well as a motor planning skill that they could work on, but that's not something that I could work on in the school system because it's not really school related.
So, if you could go back in time, what advice would you give your high school self about the future?
Oh, talk less and listen more. That's that's a tough one. Ooh, well, gosh, if we had another hour, I could come up with an entire manuscript of things I wish I could tell my high school self. But when it comes down to everything that you've done up to this point, right, has created who you are. So whether it's a mistake or a success, you've learned from both. And I've made a lot of mistakes. I feel like those have created the person that I am today. So I don't think I could change anything, but I definitely could give myself some tips.
And another one of our members asked, do you ever use artistic or musical therapy? And does that ever contribute to occupational therapy?
Absolutely.
Hmm.
Now, before I talk to you about this, there are actual music therapists. So there is a discipline within a discipline called music therapy, but we do use things like sonomas and listening therapy. So we use different decibels of sound for students to, we're kind of trying to hijack their brain and allow them to simultaneously subconsciously concentrate on the sounds, the digital sounds that are going through headphones, while also listening to a teacher or an instructor teach something. So we do use both of those. And then artistic, of course, gosh, I've had students that couldn't color or write turn into unbelievable artists. So the transition from them being able to manipulate the tip of a pencil or the tip of a paintbrush, going from an inability to an unbelievable success, that happens often as well.
And to go from like not being able to draw to being able to draw, was there certain technologies that you use, or like what kind of therapy did you or treatment did you go about for that specific case?
Sure. So we use a corded tip, um, basically a proximal stability to um, we have to strengthen the core so that then the core holds the body in place and you're not slouching and falling all over the place. And then we work toward the shoulder, elbow, wrist, and hand so that we're working on strength because dexterity doesn't come unless you have stability. So a lot of our approaches come from being able to strengthen the body enough so that it's stable. And then from the stability, they can be dynamic. They can start to use intrinsic musculature within the hand. And if you can imagine, I'll do it with my hand. If you don't have stability here and you have to use large muscle groups to do writing or coloring, anything like that, it's not going to be precise. In addition to not being precise, it uses a lot of energy because there are large muscles moving. And then when you develop the stability and you're using just small intrinsic musculature, well, it doesn't have a large metabolic, it doesn't use a lot of energy. And you can be very precise. So you can do it for a much longer period of time.
Oh yeah, that was really interesting. I haven't really heard that much about artistic therapy, so and how it played into occupational therapy. Okay, well, thank you so much, Dr. Guinn, for your time. And
Oh,
to
you're
close our
welcome.
event, we want to thank you for everyone who joined and making and asking the questions and making it interactive.
Absolutely. Thanks for having me.
Of course.
It was very informational. Thank you so much.
You're welcome. Y'all have a great night.
You too.
And so we're going to leave the QR code up for attendance for about 30 more seconds. And remember to get the 2 credits for this, you will have to complete it by November 30th, which is going to be this Wednesday by 4 p.m. And this video will be posted on our YouTube channel. So thank you guys so much for coming and have a great night.